Hey everyone, so let me start with a fundamental question when we are discussing the renal tubular acidosis. And the question is that how does the kidney defend us against the acidosis? How does the kidney defend us against the acidosis? And you have to remember out that our blood pH is tightly regulated. When the body is producing too much acid from metabolism, from the diet, from the lactic acid, the kidneys have two main jobs, right? The first, they must reabsorb all the filtered bicarbonate, as we have learned, and they also must generate the new bicarbonates to replace what was consumed by buffering those acids, right? Because the bicarbonates, they do play a role of the buffer system into our body. And this generation happens by excreting more and more hydrogen ions. So whenever our cell starts secreting more and more hydrogen ions in the urine, often bound to the buffers, like for example, that we have learned with the ammonia, right? And also the phosphate groups. So that is the more and more the buffer system manages itself by the help of the ammonia and the phosphate groups to release more and more hydrogen ions in the urine. And if there is a defect in either of these processes, for example, in the bicarbonate reabsorption or the hydrogen ion excretion, the result is a normal anion gap metabolic acidosis, and which we have also discussed that, and this is also known as the hypercholoremic metabolic acidosis. So that is the one of the hallmark of all of the renal tubular acidosis. Okay, so we classify the renal tubular acidosis into the type 1, into the type 2, and also the type 4-1. And if you remember actually the physiology of where each of that process occurs, you are not going to confuse them. Again, the first one that we are going to discuss is the distal renal tubular acidosis, that is the RTA type 1. So the name actually tells you that where the problem lies, the distal part of the nephron. Where does this problem lies? The distal part of the nephron, and specifically in which of the cells? The alpha intercalated cells in collecting tubules. So if we just revisit those alpha intercalated cells, what is their primary job? Okay, so these cells, do remember out, they have an hydrogen ATPases, right? Hydrogen ion ATPases on their apical membrane. On their apical membrane, they do have the hydrogen ion ATPases, and their main job is actually to actively pump the hydrogen ions back into the urine, right? And for every of the hydrogen ion they pump out, they generate a new bicarbonate and send it back into the blood via another of the exchanger, which was HCO3, the bicarbonate chloride pump, the bicarbonate chloride exchanger, and that is actually been present on the basolateral side, this exchanger. And you have to remember it out that the kidney in this such a way generates the new bicarbonate to replenish what was actually lost before. And over here you can just see that RTA type 1 happens into the alpha intercalated cells, right? The luminal side is facing the urine, the tissue side is facing the blood, right? And we do have the bicarbonate formation, right? We do have the bicarbonate formation, and over here you can just simply remember out you can now try to predict all the consequences, right, step by step. And let's look up to that one. Over here you can just simply remember out that what is going to be the consequences in the RTA type 1. The first one, of course, we know metabolic acidosis. Why does the metabolic acidosis happens out? Because there is a defect in the ability of intercalated cells, right? And now these intercalated cells, they cannot secrete the hydrogen ion, and there is not going to be generation of any sort of the bicarbonate. And whenever there is no generation of the bicarbonate, it means that the person is developing the metabolic acidosis. Why is that? Because the blood starts becoming acidic. Okay, and whenever you check out the pH is always and always the classic diagnostic tool, right? The 5.5, you have to remember it out. And usually in a healthy person, when a blood is acidic, right, the kidney should maximally secrete the hydrogen ion, driving the urine pH down to this value, right? But whenever a person is having the RTA type 1, so the hydrogen pump is defective. So even the blood is acidic, the urine cannot be acidified, right? So the urine pH remains inappropriately high and above, always above 5.5. We often say that the urine is inappropriately alkaline in the phases of the systemic acidosis. Okay, another thing that you can face up in this one, that the serum potassium level is lower, which is mean that the hypokalemic state, right? And why would the potassium be low? So think back to the collecting tubule. The alpha intercalated cells, the hydrogen pump is failing, but remember the principal cells are still there, right? We have learned about the alpha, the beta, and the principal cells, and there are and these principal cells are influenced by the lumen voltage. The principal cells are actually influenced by the lumen voltage, right? So normally whenever the hydrogen secretion helps it maintain the lumen positive environment, so without it there is less opposition to the potassium secretion, and more importantly the chronic acidosis itself can impair the potassium reabsorption in the tubule. So the net result is going to be that the urinary potassium is wasting and hypokalemia is going to be seen into such patients. And then we can look up to the calcium phosphate kidney stones. Why is that? The calcium phosphate kidney stones, why is there is the risk associated with these ones? So you have to remember out that why do these patients form the stones, right? That should be the question that could come to your mind. So for there are altogether two reasons, but the first one is because they cannot acidify their urine, and the urine pH is highly alkaline, right? And the calcium phosphate stones form preferentially in the alkaline urine. The second reason is because the body is in a state of the chronic acidosis. The bones act as a buffer. So the body leaches or try to actually leach the calcium and the phosphate from the bones to neutralize the acid. So this leads to the hypercalciuria. The term is hypercalciuria. And what is that hypercalciuria? That means that we do have actually the higher calcium in the urine. This is just like we have learned the higher sodium in the urine, right? So the hypercalciuria, high calcium in the urine, and increased bone turnover. So you have high calcium and the alkaline urine, that is actually making out the calcium phosphate kidney stones, right? The risk of the calcium phosphate kidney stones. So remember out the two reasons when you are explaining up that why do we occur or why do we have the risk of the calcium phosphate kidneys, right? Okay, another thing that you can now touch up, what causes the type 1, right? The causes of the RTA type 1. The first one you can remember out this could be congenital, right? This could be the congenital, and this is associated with the structural abnormalities of the urinary tract. And this can also be acquired from the autoimmune diseases like SLEs. SLEs are the systemic lupus erythematosus, erythematosus, right? The SLEs, systemic lupus erythematosus. Erythematosus. Systemic SLEs, and these can also be caused by the analgesic nephropathies or either from the antifungal drugs. For example, the amphotericin B toxicity. This is one of the antifungal drug. Okay, amphotericin B toxicity, and also you can remember out that this is going to be toxic, right, to the collecting tubule too. So you can just try to remember out while discussing the RTA type 1 that this is a defect in the distal hydrogen ion secretion, which leads up to the distal hydrogen secretion, where specifically in the alpha intercalated cells, and this leads up the inability of the acid secretion and inability to acidify the urine, and the pH becomes actually greater than 5.5. The environment leads up to the hypokalemia, and there is absolutely the risk of the calcium phosphate stones, right, into these patients.